Lection number 3. Diseases of the throat. Here you see the pharynx and larynx. Acute tonsillitis is general infection disease in which the lymphoid tissue of the tonsils is affected by inflammation. In most cases, the palatal tonsils are affected while the other tonsils are involved less frequently. Etiology and pathogenesis. Coccus, bacilli, viruses, spirocheta, fungi, beta-hemolytic streptococcus of group A, Staphylococcus aureus, and adenoviruses. Occasional tonsillitis manifested as autoinfection. Epidemic from arising as a result of infections from a tonsillitis patient. Exacerbation of chronic tonsillitis. The commonly used classification includes the following forms. First, catarrhal. Second, follicular. Third, lacunar. Fourth, fibrinose. Fifth, herpetic. Sixth, phlegmonose, intratonsillar abscess. 7. Necrotic, gangrenose, and 8. Mixed forms. Acute catarrhal tonsillitis. Dilatation of small blood and lymphatic vessels in the parenchyma of tonsils. The onset is acute and is marked by dryness, burning, and tickling in the throat, painful swallowing, general indisposition, subfebrilar body temperature, insignificant inflammatory changes in the peripheral blood. Pharyngoscopy reveals diffuse hyperemia of tonsils and the margin of the palatal arch. The tonsils are somewhat enlarged. The regional lymph nodes are often slightly enlarged. The disease must be differentiated with ARVI. Follicular tonsillitis begins with elevation of temperature to 38-39 degrees, strong pain in swallowing, the changes in the blood, and often pronounced. Neutrophilic cytosis, increasing of ESR, trace of protein in the urine. Pharyngoscopy reveals diffuse hyperemia and infiltration of the soft palate and the arch. The tonsils are hyperemic and enlarged, with numerous yellowish or yellowish-white spots from 1 to 3 mm elevated over the surface. These formations are separating follicles. The regional lymph nodes are enlarged and painful. Disease should be differentiated with leptotrichosis. Lacunar tonsillitis. More severe course than follicular, toxemia is severe. Pharyngoscopic picture is characterized by enlargement of hyperemic tonsils, which are covered with cells of yellowish coat, first in lacunar orifices. Disease should be differentiated with diphtheria. Treatment. The patient should be separated from the others. In very severe cases, the patient should be hospitalized. Food should be not irritating. Gargling with warm solutions of antiseptics. Non-specific anti-inflammatory drugs. The antibiotics is administered usually from 5 up to 10 days. And desensitized drugs. Necrotic, ulcerous necrotic tonsillitis of Szymanowski-Winsand. Symbiosis of Bacillus fusiformis and Spirocheta buccalis. The morphological changes, necrosis of the surface of one tonsil with formation of an ulcer from floor is covered with a loose fibrinous membrane. The patient complains of discomfort in the throat during swallowing, fetid breath, and hypersalivation. Swallowing is usually painless. The body temperature is usually normal. Peritonsillitis or quinsing. Inflammation of the peritonsillar cellular tissue is a complication of acute tonsillitis, foreign body or autogenic etiology. The development of the process has 3 stages: the edema, infiltrative, purulent, and reconvalescent stage. A peritoneal abscess can be in the anterior or anterior superior, posterior, inferior, and the lateral parts. Symptoms: severe pain during swallowing. It radiates into the ear, teeth. The patient refuses food and drinks. Headache and fatigue. The body temperature rises to febrile. Trismus or chewing muscles develops. The speech becomes nasal. Inflammation of the cervical lymphoid nodus, and the inflammative changes in the blood. Pharyngoscopy is difficult due to trismus. Peritonsilitis are characterized by marked hyperemia, protrusion of tonsilla, together with the palatal arcs and the soft palate towards the median line. The uvula is moved to the opposite side. The tongue is covered with a thick coat. The saliva is viscous. Fluctuation is observed in the region of the strongest protrusion. Treatment: the patient must be hospitalized. Intramuscular antibiotic therapy is indicated for all stages. The abscess is usually incised with a local anesthesia with a 10% lidocaine. The incision should be done at the most prominent site. Tonsillectomy is indicated in cases when the opening of abscess is impossible, lateral peritonsillitis, persistent course of the disease, and in the presence of signs of complications, such as sepsis, parapharyngeal abscess, phlegmon of the neck, and mediastinitis. Retropharyngeal abscess. Inflammation of the lymph nodes and loose connective tissue found between the fascia of the pharyngeal muscles and the perivertebral fascia. The disease occurs almost exclusively in children because presents the lymph nodes up to the age of 4. Symptoms: pain in the throat during swallowing and laborious breathing. The child refuses food, becomes restless, and often cries. The temperature rises to 38-39 degrees. Respiration through the nose becomes difficult, speech is nasal, a laryngeal stridor can develop, the voice becomes hoarse, and respiration noisy. Asphyxia and cyanosis develop. The reaction of the regional lymph nodes is usually pronounced. Pharyngoscopy reveals protrusion and hyperemia of mucosa only one half of the posterior pharyngeal wall. The blood reacts to the inflammation. When an abscess develops, it should immediately be opened. Measures should be taken to prevent aspiration of pus. This can be attained by preliminary suction of pus during puncture. The abscess should preferably be opened at a half-lying patient. Infectious mononucleosis caused by a lymphotropic virus. The disease is characterized by a fever, different type of tonsillitis, adenosplenomegaly, and changes in the blood, high counts of leukocytes, and atypical monocytes. The most characteristic symptoms of the disease is the moderate leukocytosis with a predominance of mononuclear cells, which may number 50 to 90% of the total leukocytes, a great number of altered monocytes. Blood examination to Epstein-Barr virus. Treatment: bed rest and high-calorie diet. Antibacterial preparations prevent secondary infection. Gargling with disinfectants or aseptic solution. Chronic tonsillitis. Infectious allergic disease of human body. Predisposing factors. Anatomical topographic properties of the tonsils. Presence of pathological microflora in lacunae. Disordered protective adaptation mechanisms in tonsils. Chronic tonsillitis is usually secondary to acute tonsillitis. Autoallergic mechanisms of the onset of tonsils. Hypertrophy of pharyngeal tonsils, adenoids. Adenoids usually grow at the age from 3 to 15. The symptoms: bad nasal respiration, constant nasal discharge, dysfunction of the auditory tubes, and the recurrent inflammation of the nasopharynx and the nasal cavity. The inferior jaw becomes narrow and long. The hard palate undergoes malformations. It becomes high and narrow. Incorrectly growing teeth cause malocclusion. Their changes give a specific dull expression to the face of children with adenoid growth. Adenoid face, so-called adenoid face, can develop pigeon chest. Children are usually petite. Endoscopy, palpation of nasopharynx confirm the diagnosis. The degrees. First, adenoids covered to 1/3 of the vomer. Second, about half of the vomer is covered. Third, the vomer is covered to 2/3 or almost completely. Treatment of adenoids is commonly surgical. The operation is usually performed at the age from 5 to 7. Acute laryngitis, inflammation of the larynx. Catheteral laryngitis, etiology, respiratory viruses, bacterial flora. Clinical signs, quick start at a satisfactory condition. Normal body temperature, dryness, sore throat, dry damp coughing, hoarseness. Treatment, voice regime, dry cough, Tosuprex, Falimine, Libexin. Damp cough, ACC, Sinopret, Mucoltine, Bromhexine. Inhalations with the inflammative drugs, Decasan, Traces. Aerosols, Cameton, Ingalipt, Camphomen. Installation larynx, 1% oil solution of menthol, antibiotics, hydrocortisone, 1% solution, Protergol or Collargol. Antibiotics, antihistamine, drugs, calcium, and vitamin C. Phlegmonopharyngitis, acute purulent inflammation of the submucosal layer, muscles and ligaments of the larynx. Epiglottitis, abscess can be formed. Chondroperichondritis of the larynx. Pain, painful swallowing, high body temperature, hoarseness, difficult breathing, smoothness of larynx contours, increase in volume of a neck, complication, a cicatrolaryngal stenosis. Treatment, antibiotics, corticosteroids, detoxification, diuretics, opening of abscess, in case of decompensated stenosis, tracheotomy. Acute stenosis, laryngotrachea bronchitis in children, subglottic laryngitis, Fels group. Main symptoms, voice change, barking cough, difficult breathing due to swelling of submucosal layer of subglottic spaces. Differential diagnosis, diphtheria, retropharyngeal abscess, foreign body, bronchial asthma, papillomatosis of the larynx. Chronic laryngitis may be catheteral, atrophic, and hypertrophic, and also can be diffuse and circumscribed. Here you see the different laryngitis. Diffuse, single nodules of vocal cord, polyps of larynx, leukoplakia, edema of larynx. 9 tumors of the larynx: epithelial papilloma, connective tissue fibroma, vascular angioma, mixed angiofibroma, rare chondroma, teratoma. Symptoms: hoarseness of voice, dysphonia, aphonia. Diagnosis: indirect or direct laryngoscopy, biopsy. Treatment is surgical, endolaryngeal removal, enlarged tumors, laryngeal fissure, and tracheotomy. Morphological classification of the tumors of the ENT organs. First type, highly differentiated tumors, benign osteoma, chondroma, lipoma, fibroma, angioma, adenoma, neuroma, and so on. Second type, malignant tumors, cancer, third grade, highly differentiated cancer, second grade, cancer of the moderate degree of maturity, third grade, low differentiated cancer, fourth grade, undifferentiated cancer. International classification of cancer. The concept about the stage of the process is ENT oncology. The stage of the process can be first, second, third, fourth. It is determined in the form of the combinations of symbols T tumor from 1 up to 4 and N nodules from 0 to 3 and M metastasis, yes or no, 0 or 1. Laryngostenosis, narrowing of the larynx, acute, second days, swell, inflammation, allergic reaction, trauma, foreign bodies, acute laryngotracheitis in children, diphtheria of the throat, laryngospasm, chronic, weeks, years, tumors, cysts, infectious granulomas, scarifications, inborn pathology, two sides paralysis of recurrent nerves. Classification. The first stage of compensation. It is characterized by deepening and less frequent respiratory excursions, loss of a respiratory pulse only during physical activity. The second stage, a stage of subcompensation. At this stage, additional muscles take part in the breathing act. One can clearly notice in the patient retractions of over and subclavian fossa, intercostal intervals, inflating, trembling of wings of a nose. Breath is accompanied by nose, stridor. Mucous membrane of lips becomes cyanotic. In the third stage, decompensation, stridor more expressed, tension of respiratory muscles becomes maximal. The patient shows significant anxiety and disturbance. He becomes covered with cold sweat, cyanosis progresses, breathing becomes fragment, superficial, the arterial pressure decreased, pulse threat. Fourth stage, asphyxia, pupils extend, there comes loss of consciousness, involuntary urination and defecation, and the patient dies. Aid in case of laryngostenosis. In allergic immediate administration of adrenaline, 0.5, 1.0 milliliters of 0.1% solution of adrenaline, epinephrine, corticosteroids, antihistamines. Intravenous, soluция глюкозы, soluция кальция хлориде, soluция ацидия аскорбиницы, soluция фелини, soluция преднизолоне, antihistamine, dimedrol, diuretics, Lasix, Trifast. Distraction procedures, inhalation of moisture oxygen, dissection of the abscess, intubation, tracheotomy, conicotomy. Indications for tracheostomy. Prophylaxis of mechanical asphyxia, drainage of the respiratory pathways, long-term intubation. Tracheotomy is divided in two, upper, middle, lower. It depends on position of thyroid gland isthmus. Position of the patient during tracheotomy. Here tracheotomy. Next picture. Next picture. Next. Tracheocanula with put in trachea. Tracheostomy complications. Bleeding, emphysema of subcutaneous fat tissue, pneumothorax, pneumomediastinum. Respiratory stimulus during a trachea cut, esophagus injury, purulent tracheobronchitis in the postoperative period. Injury of rear wall of the trachea and of the esophagus during tracheostomy, you see on this picture. Conicotomy. An extremely emergent interventions in case of severe acute asphyxia when there is no time for tracheotomy and intubation is for weather reasons impossible. Conicotomy is recommended. Dissection of the thyroidal membranes, conic ligament. You see on the picture how it to do. Thank you for your attention.